Hi, I'm Jefferys from the Treatment Action Group, an advocacy organization in New York City. And I'm here with Timothy Henrich from Brigham and Women's Hospital and Harvard Medical School. Is that correct?
That's correct. Mm-hmm.
And we're going to talk about the data that Dr. Henrich is presenting at CROI this year. And it's the study that's received quite a bit of media attention. And so I'm going to hand it over and ask you to describe what the results you're going to be presenting here.
Sure. So I'm presenting an update on the Boston patients, as our patients are commonly known, which are two men living with HIV that underwent allogeneic stem cell or bone marrow transplantation for lymphoma. And we had previously presented that after stem cell transplantation, and this is a procedure where the patients are given chemotherapy to reduce the amount of blood cells in their body, and then they get cells from a donor, in these cases HIV negative donors, for treatment of their malignancies. Now, what was interesting is that about 8 to 9 months after the donor cells were infused into the patients and essentially took over, so these donor cells became nearly 100% of the cells that were in their peripheral blood or in the bloodstream, we were unable to identify HIV, either HIV in the cells, HIV in plasma, and in one patient, we were even able to get rectal tissue to look at gut biopsy or gut tissue and found that there was no easily identifiable HIV in that tissue as well. So I think we were all very excited to really see a lack of detectable HIV after a particular intervention, which, although is risky in and of itself, was a proof of concept that giving chemotherapy followed by stem cell infusion could potentially lead to the loss of detectable HIV in the body. And what we have done thus far is decided that since we weren't able to find HIV, even after we looked in hundreds of millions of cells and we looked very deeply for presence of HIV, that we would ask the patients to stop their antiretroviral therapy to see if virus would come back, and if so, how the virus would come back. So what we did was we asked, again, both individuals to stop their therapy, and they were both willing to do this and understood that there were potential risks involved of doing this, and certainly we were aware of that as well and wanted to make sure that we did this very safely. So what we did was we did weekly viral load monitoring for HIV viral load. We also did weekly to biweekly testing of HIV in the blood cells themselves as well, in addition to some super sensitive research assays at certain intervals. And what we found was that in one of the patients, the virus actually did come back approximately 3 months after they stopped their antiretroviral therapy. And in the second patient actually went for 8 months before we saw any evidence of the virus return. Now, it was disappointing, I think, for the patients and ourselves and for folks to see that the virus did rebound, but I should mention that normally HIV comes back within 1 to 4 weeks, almost invariably, after antiretroviral therapy is discontinued. A few patients have gone a little bit longer than that, but essentially it's within weeks we see the rebound, and I think in the 2 patients we actually had no evidence of virus until at least 3 to 8 months after they stopped their therapy, suggesting that there was a reduction in the total amount of HIV in the body or the reservoir, and that it may have had an impact, at least a transient impact on keeping virus at bay, I guess you could say, for some time. That said, it looks like the virus that came back was related to the virus that was in their bodies before the treatment interruption and before the transplantation. And that's the major finding that we'll be presenting this week.
Okay, thank you. And is there, I mean, are there things from it that you think are encouraging in terms of future research? I know it's been kind of disappointing, I'm sure, for the individuals and for the field to some extent, but are there lessons here that could be translated into future research?
Absolutely. It certainly was, as you mentioned, it was disappointing, I think, for particularly the individuals involved in the study and for us as well. And we've gotten to know the patients very well. And so it was disappointing. But I think the take-home message is that we're learning a great deal about how HIV persists, where HIV persists, or at least we're hoping to learn this. And that there is optimism that, we had one patient that went 8 months without any detectable virus in the blood at that time. And so I think it's progress, if it's not permanent, permanent antiretroviral-free remission, as you could say, that we're starting to learn a little bit about how the virus persists. And we're also learning about what types of science we can learn from the transplant themselves to potentially make this more accessible to more patients. So for example, how is the immune system different after transplantation? Or how can we start to harness part of these graft versus host effects, which is essentially the donor cells, when they come in, have activity against the host or recipient cells, and they actually have activity against cells that potentially harbor HIV disease. And another interesting facet that we want to explore, and I think other people are interested as well, is how can we harness some of these some of the immune function or phenomenon that we see in graft versus host effects or graft versus host disease, and be able to kind of turn that against HIV without having to do full transplantation, or how we can learn from that. So although disappointing, I agree with you that we're certainly learning a great deal, and I think this is really going to help us propel forward. And if you can't always succeed at the first time,
Sure.
So we kind of go back to the drawing board, take what we've learned, and I think we have a much better approach, and we're going to be in a better position the next time for whatever that process or procedure may be.
Are there other people that might be candidates for this procedure that where you'll look at the same kind of issues?
So we're right now at bone marrow transplant, because there's about a 15 or 20% mortality just from the transplant itself, at least the type of transplant that our patients get. It is not a scalable modality that we want to give to a majority of patients with living with HIV. It's just not practical. Patients often have to go onto long-term immunosuppressive medications, so although they can potentially stop ART for a little while, it doesn't guarantee that they're going to be off or on fewer medications and have less morbidity. And because of that, we don't suggest this, obviously, for folks that don't need a transplant, usually for hematologic malignancies and cancer, but there's some other syndromes where folks may require bone marrow transplant. That said, we are still actively enrolling and currently looking for patients, and have enrolled several more patients that are far earlier in the process that needed bone marrow transplantation. And I think that we're certainly, over the next year or two, will learn quite a bit about not just 2 or 3 individuals, the Berlin patient and a few smattering of other individuals, but as we get more and more patients that undergo this procedure, I think we're going to learn a lot more. So we're certainly doing that. There's other places in the US and in Europe that are also working on these cohorts that will be really interesting and very important, I think, to help inform us.
When the virus came back in these individuals, were there immune responses that developed to the virus with their new immune system? Was there anything there before?
Well, it's interesting that because their transplant involved HIV-negative donors, their new immune systems after transplant appear, and we'll present this data as well, appear naive to HIV. In other words, they don't recognize HIV. At least the cells don't recognize HIV. There is also a decrease in antibody levels. So we know that the anti-HIV antibodies that they had before transplant do decay, and they decay fairly robustly after transplantation. But there is a little bit of persistence of antibody. That said, what we did notice is that when virus returned, it returned very much like what we see in acute retroviral infection. So in someone who has not had immune system that is not aware of the virus, and all of a sudden there can be a very rapid rise in the viral load. So we saw that as well, suggesting that really the immune system was naive to HIV, particularly because it was from a donor, or
Sure.
a large component was from a donor that was HIV negative. That said, about maybe 2 weeks after transplantation, after viral rebound, we do start to see return of HIV-specific immune cells, for example, that recognize HIV, and also, at least in one patient, the antibodies seem to be going up a little bit, but in one patient they seem to be going down. So again, a few patients, it's hard to know what to make of this, but at least we know that during or after transplantation, even during the treatment interruption, there was no recognizable or easy recognizable HIV immunity or any changes in that. Yeah.
Do you have maybe a sense of how many infected cells were left?
We have an estimate. It's very difficult to know, because the problem with studying HIV reservoirs is that it can exist in tissues, for example, lymph nodes, spleen, potentially the brain, the gut, liver. I mean, it's potential that there are long-lived reservoir cells in these different tissues, and it's actually difficult to get to a lot of the tissues for that type of work. So it's possible that there were cells that we're just not finding, or we were not accessible to the types of interventions that we were doing or testing that we were doing. But when we look at mathematical modeling, so we try to estimate this, and this was work with Alison Hill that had originally worked with Bob Silicano, who has done a huge amount of work on the HIV reservoir. What their data suggests that it doesn't take that many cells to reseed after an intervention. So for example, as low as maybe a couple hundred infected cells that are capable of making replication-competent HIV that are left in the body may be sufficient to reseed and cause viral rebound after the treatment interruption. And I think that estimated in our patients, we thought maybe hundreds to maybe low thousands of the number of cells that are still latently infected in the body. But again, it's really hard to know if that's reality or not, but at least that's an estimate that we think about. So it doesn't take that many, unfortunately.
Okay.
Yeah.
And is that kind of a benchmark that where we're going to have to do better than that? Maybe?
I think so. So if we're looking at just eliminating HIV-infected cells, we're going to have to eliminate a vast majority, if not all of them, which can be very difficult, given the fact that stem cell transplantation, which is one of the better ways to get rid of cells from the body, was not sufficient, at least without resistant cells, like in Timothy Ray Brown's case, was not enough to eradicate HIV reservoirs. So, but certainly maybe looking at strategies at eliminating cells, but also improving immune system or immune function at the same time, or a dual or even a triple approach. If you attack it from all different angles, maybe it's not just reducing the number of cells, but it's reducing the number of cells, it's boosting immune system function, et cetera, that may actually lead to ART-free remission. So that's the hope. So we're learning piece by piece, I think, at this point, but hopefully we can put all things together and see how it goes.
Excellent.
Yeah.
Okay, well, thank you very much, and I think we'll stop there.